pulmonary circulation doesn't like being hypoxic in the newborn period. So in the fetus, basically you don't need lungs, so there's no point in wasting energy and oxygen pumping blood through the lungs that aren't using it. So most of the blood that enters the right side of the heart is diverted across the ductus aorta arteriosus into the aorta. And one of the reasons why that happens is the pulmonary vessels are tightly constricted down. So very high resistance, virtually only about 5% of cardiac output goes through the pulmonary circulation. After delivery, the pulmonary arterioles sense the increase in oxygen in the airways and air sacs and respond to that by rapidly dilating. And so pulmonary blood flow increases very quickly. However, in the newborn, as we know from animal models, that for a period possibly up to some weeks, the pulmonary circulation remains very sensitive to the levels of oxygen in the baby's system. And if the baby becomes hypoxic, the baby responds to that by going back into pulmonary vascular vasoconstriction, and you can't push blood through the lungs. So in that situation, it doesn't matter how well you ventilate them, you can't oxygenate the baby. So the pulmonary circulation is very important. The other thing that's important about the way the pulmonary circulation works is the pulmonary circulation is very dependent on lung volumes. So there's basically two types of capillary networks in the lung. So you've got capillaries that sit in the alveolar walls, and these vessels at low lung volumes, they can expand up nicely because there's no pressure on them. So at low lung volumes, the pulmonary vascular resistance is low. As you inflate the lungs, the pulmonary vascular resistance progressively increases. Then you've got a second set of pulmonary capillaries, and these are in the interstitial tissues, and they work differently. So at low lung volumes, they tend to collapse down. As the lungs open up, the connective tissues pull these vessels open, so they behave differently. So at low lung volumes, the pulmonary vascular resistance is very high, and as you inflate the lungs, the pulmonary vascular resistance drops. When you put all this together, you get this U-shaped curve of pulmonary vascular resistance. So at low lung volumes and at high lung volume, the pulmonary vascular resistance is high. At functional residual capacity, the pulmonary vascular resistance is at its lowest. So not only is getting the baby to functional residual capacity, the ideal functional residual capacity, important from a pulmonary ventilation mechanics point of view, but it's also very important from a lung perfusion point of view. So when you set up your ventilator so that you're achieving good lung volumes, not too much, not too little, that's where you get your best perfusion and your best oxygenation. And we can see the importance of that. So when a baby's lungs collapse down, they're very difficult to oxygenate. If you get too aggressive with your ventilation and overinflate them, oxygenation goes off as well. So getting the lung volumes has important effects on lung circulation. But then it gets just a little bit more complicated than that, because effectively squeezing the blood out of the intravalvular capillaries. But then, because you've got this high vascular resistance, the return of blood from the lungs to the left atrium is significantly reduced. And the way the heart responds to that is that you have less preload, which I'll talk about a bit later. And what that does is it actually reduces contractility of the heart if the heart is underfilled. And so you get reduced cardiac output. So not only are you affecting the lung circulation, but you're actually affecting the body circulation if you overinflate the lungs. And so one of the clues you can look at when you're sort of dealing with a baby who's difficult to oxygenate, difficult to ventilate, you've got moderately high ventilation and you're thinking to yourself, do I need to go up on the pressures or do I need to go down on the pressures? If you have an arterial line in the baby, what you can do is you can watch and see what changes in the ventilator do to the arterial blood pressures. So one of the things you can do is you can reduce the pressure and you see the blood pressure go up. You know that baby is overinflated. And if you increase the ventilation pressures, you actually don't help the baby. You really need to decrease the ventilation pressures. So this sort of interaction, you can read all the signs to try and work out, do I need more peak? Do I need less peak? Do I need bigger tidal volumes? Do I need lesser tidal volumes? By reading not just what's happening on the ventilator, but actually what's happening on the cardiovascular monitoring as well. What's interesting about hyalomembrane disease, which is a pathological diagnosis, is that most of the injury microscopically is in the small airways, close to where they meet the air sacs. And that's something that I didn't realise until I started working in the United States. And it explains, as I'll go on to show you, why things like CPAP works and why positive pressure works. Surfactant deficiency, important. In fact, the very immature baby, a lot of them have quite reasonable amounts of surfactant, but it's not functionally mature, so it doesn't work very well. If a newborn infant with respiratory distress syndrome doesn't receive exogenous surfactant, their own pool of surfactant gradually builds up over a period of 4 to 5 days. So that's why you see an infant with respiratory distress syndrome who you just leave alone and they put some oxygen. They sort of start to get worse for a little while, and then over a period of days they get better. A significant amount of that is related to them producing their own surfactant. Most of this is due to their own production. And because soon after birth they already start producing their own surfactant and maturing their own surfactant, it's one of the reasons why we don't give surfactant after 48 hours, because by that point in time the babies have got enough surfactant. But if you give them the artificial surfactant, it doesn't really change things a whole lot, and you don't see the babies get much better. What's interesting though is the baby's own surfactant seems to be much more efficient than any surfactant we give the baby. So even relatively small amounts of surfactant made by the baby is much more effective than the big loads of surfactant we give babies, which is why we do see some quite immature babies with minimal amount of respiratory distress. They don't have much surfactant, but it's enough. The other interesting thing about surfactant production is we now know from animal experimentation that providing CPAP actually accelerates surfactant production. So that's why you can take a very premature baby and put them on CPAP and not have to give them surfactant. And they cope because the CPAP itself actually accelerates the production of surfactant. With, it's a very busy slide, sorry. With surfactant, we often think of surfactant deficiency as being the same in the whole lung, but it's not. That each little air sac, each little airway is affected individually. So some parts of the lung are more affected than other parts of the lung. And that actually has sort of quite important effects. So one of the important things about surfactant is that the distensibility of the air sac is affected by the volume of the air sac. So what surfactant does is, so if we don't have surfactant, small lung units have a much greater tendency to collapse than big lung units with more surfactant in them. And so what happens is that the already collapsed surfactant deficient lung units collapse into the bigger lung unit. And this is what we refer to as the two-compartment lung model. So what we say is some of the lung has more surfactant in it. So at a constant pressure coming down the airway, those air sacs are more distended. More importantly, surfactant also affects the terminal airways. And so if you've got enough surfactant, the terminal airways are nicely opened up. And what that means is every time you take a breath, you get a reasonable volume of gas into that lung unit. With that reasonable volume of gas, you get lots of oxygen molecules. When the pulmonary circulation close to that air sac senses that oxygen, it dilates up, so you get blood flow past it and you get good oxygenation coming from that little lung unit. If you then have a lung unit that has low surfactant, the air sac is collapsed down, but also this small airway is very collapsed down. And in effect, you get limited or no gas exchange into this lung unit. So there's very little oxygen in that lung unit. The capillary circulation going past it senses that and constricts right down. So it shunts, venous blood shunts away from the lung units. And so you get a mixture of oxygenated and deoxygenated blood entering back into the circulation, giving you systemic hypoxia. And the more surfactant deficiency you've got, the greater this effect is. In terms, so that's oxygen, but it also affects CO2. So if you've got these very collapsed airways and very collapsed lung units with only very small amounts of gas exchange occurring, the rate of CO2 exchange from the circulation back into the airways and out to the outside world is dramatically reduced. So you've got reduced alveolar volume, you get reduced tidal volume, so you get reduced CO2 elimination and you get systemic hypercarbia. So that's why in our premature babies' lungs you get this pattern of systemic hypoxia and systemic hypercapnia. It's largely due to the effects on the small airways causing collapse and poor ventilation of those lung units. So, and this model explains why babies respond to treatments that we give them. So if we just give them supplemental oxygen why does it improve their overall oxygenation? And sometimes you'll see a baby saturating 70-80%, and just 30% oxygen can be enough to make them saturate normally. And you think, how can this be? The reason is that with higher concentration oxygen, although the gas volume going down into this lung unit is reduced, it's got a lot more oxygen molecules in it. So you no longer have hypoxic area here. So the pulmonary vessels supplying that lung unit dilate up, and you're now getting oxygenated blood entering the system, and you're correcting your systemic hypoxia. So that's a large amount of why just giving supplemental oxygen to a baby with RDS makes them better. But how does CPAP make a baby oxygenate better and also improve their carbon dioxide exchange? When you think about it, it makes no sense. You're not forcing a bigger tidal volume into them with each breath. So how can you make the CO2 go from 80 down to 40 just by simply putting CPAP pressure? And the reason is, what the positive pressure does is it opens up these airways, it splits them open, and to a certain extent increases the volume of these lung sacs. So you get more gas coming in, which means more oxygen. You get correction of the pulmonary vasoconstriction in response to the more oxygen. But you're also getting larger volumes of gas going in and out, so you correct the CO2. So that's how CPAP works. And that's why you can, in a lot of babies who you would think would need a ventilator, CPAP can actually be enough. If their respiratory drive is good, CPAP can be enough to correct their breathing problems. It helps generate more surfactant, it overcomes hypoxia, it overcomes CO2. But unfortunately, CPAP isn't enough for a lot of babies. So let's look at some of the basic principles of mechanical ventilation. So mechanical ventilation is actually a very, very simple process. And we can see that from the way a neopuff works. A neopuff is a very simple device, but you can ventilate somebody with it. So the way a ventilator basically works is you've got constant flow of a gas through the circuit with a connection to the patient through the ET tube. You can adjust the resting pressure in that circuit by basically tightening down on the airway or releasing it. If you narrow the airway down, you get higher resistance, so you get higher pressure in the circuit. That's your peak. You generate PIP by closing off the expiratory valve. The gas keeps flowing in, it pushes the pressure up, and the pressure keeps going up until you open the inspiratory valve again. And as the pressure increases in the circuit, it drives gas into the patient. So very simple procedure. Most of our high-tech ventilators, all that they're really doing is they have clever sensors and clever software that allow you to measure gas flow in and out, so that you can set your tidal volumes, you know when to turn off the pressurizing to get the adequate amount. So the actual basic principle of the ventilator is no different. Most of it is just being really, really clever so we don't have to think about it and try and adjust it all ourselves. So with conventional ventilation, how does oxygenation work? So oxygenation is largely dependent on lung volume. So lung recruitment increases the amount of gas volume in the lungs, increases the amount of oxygen molecules in the lungs, overcomes the shunt effect from the pulmonary vasoconstriction. So mean airway pressure, correcting ventilation perfusion mismatch, is largely what the ventilator is doing. And in a conventional ventilator, there are a number of ways you can change the mean airway pressure. Some are good ways, some are bad ways. So you can change the mean airway pressure by increasing the inspiratory flow. So if the rate of gas going through the circuit is really high, it tends to increase the pressure in the circuit. So you increase the mean airway pressure. You can increase the peak inspiratory pressure, that increases the mean airway pressure. You can increase the peak, or you can increase the inspiratory time. But some things are more helpful than others. So we know that increasing the PIP, or the PEEP, is much more efficient way of improving oxygenation than changing the inspiratory time or inspiratory flow. We rarely touch the inspiratory flow. The key thing about inspiratory time is it's a very easy way to increase mean airway pressure, but it's also a dangerous way because inspiratory time, in big long inspiratory times in a baby with a short time constant. So that's a lung that fills quickly, empties quickly. What you're doing is you're holding the baby at full inflation for an excessive period of time. And what that tends to do is around the junction between the airway and the air sac, you develop stresses and you rupture, and then you get a pneumothorax. So inappropriately long inspiratory times in a very preterm baby have very bad effects and cause major issues with pneumothorax. So it's interesting, when I worked in the United States, we were using short inspiratory times, somewhere between about 0.2 and 0.3. In our unit, our pneumothorax rate was really low. Some of our trainees went 3 years through their training without even putting in a chest strain, which was a problem for them for when they worked in other places that had high pneumothorax rates. When I went back to Australia and started working, Australia was still set in the mind of we need long inspiratory times of 0.5 seconds. And they had high pneumothorax rates. And when I was doing intensive care, I would set up the ventilator on her inspiratory time of 0.2 to 0.3. The overnight doctors would come along and go, oh, that's stupid, nobody does that. And they put the inspiratory times up. Next morning, the baby would have 2 or 3 chest strains in from pneumothoraxes. And that was really bad because a very strong trigger for intraventricular hemorrhage is pneumothorax in the first few days of life. So not only are you damaging their lungs, but you can take a baby who's got a normal brain and turn them into a baby who's got a terrible brain just by not understanding inspiratory time. It took me 6 months to convince my colleagues that they were doing harm. And the only thing that really changed it was we had a professor come along who looked at the inspiratory times that were being used and went, oh, that's stupid, you need short inspiratory times. And because he was a professor, everybody went, oh, wow, something new, and they suddenly started changing. And it was dramatic. Pneumothorax rate dropped right down. The other thing is, more mean airway pressure is helpful to a certain extent, but as we talked about before, if you use very high mean airway pressures, you start to affect cardiac output and lung perfusion. So in fact your oxygenation goes off. So when you're increasing your mean airway pressure, you don't work on the basis if some is good, more must be better. You work on the basis that some is good, more may not be helpful. And so it's sort of balancing out the mean airway pressures. So I like this sort of graphs because it helps explain. So if we look at the area under this curve, the area both in red and blue, that area represents mean airway pressure. So anything you do to increase that area increases mean airway pressure. So you can see if I increase the size of the wave by increasing the PIP, I increase the mean airway pressure. If I push the baseline right up, which is what you do when you increase the peak, you can increase the mean airway pressure. And if you increase the length of this curve, you increase the mean airway pressure. Generally speaking, the safest way to increase mean airway pressure if you're ventilating well is to put the peak up. That has less risk than putting either the PIP up and certainly putting the inspiratory time out in a baby with a short time constant is a very dangerous thing to do. How does ventilation and carbon dioxide exchange work? Carbon dioxide exchange is a very simple equation. It's dependent on the rate at which fresh gas comes in contact with the pulmonary blood. So carbon dioxide is exchanges proportional to what we call minute volume. So the minute volume is the amount of gas that goes in and out over a minute. Minute volume can be affected by tidal volume, or it can be affected by rate. Tidal volume can be affected by PIP and sometimes by peak, which I'll explain. So same curve again. If I increase the PIP, I increase the tidal volume because the tidal volume is basically the size of this blue area. The other way that I can increase tidal volume is sometimes when the baby is overinflated, so you've got too much mean airway pressure, too high a peak, is because you're now at the top of that inflation curve. You need a lot of pressure to generate tidal volume. If you reduce the peak down to a more appropriate peak for the same pressure, you're now getting larger tidal volumes. So I've certainly had the experience where I come on and take over care of a baby, and the baby that for some reason set up the ventilation with quite high peaks, and we're needing quite high pressures to generate CO2 exchange, and the CO2 exchange is not very good. On the new ventilators with volume guarantee, it's really easy to work out what's going on. If you turn the peak down and then the pressure required to deliver the tidal volume suddenly drops right down, it tells you that your peak is too high. And the way to improve ventilation is not to keep putting the pressures up, but actually to reduce the peak. Therefore, you improve the tidal volume. You need a lot less pressure to improve the tidal volume. And so you've actually achieved improved tidal volume by reducing the peak, which makes, when you first think of it, makes no sense. But then when you think of the pulmonary mechanics, it's very clear. And so you sort of, one of the things, the real challenge is you come on for your shift, you've got a baby who's really sick, very difficult to oxygenate, very difficult to ventilate, and you have to fix it. And it is to try and work out how the baby got there, what's going wrong, and there are clues that you can use to determine whether or not the ventilation strategy they're using is good or bad. Because our first response usually to problems with oxygenation and ventilation is to increase the pressure. But as I've explained, if you have a baby who's already very over-distended, increasing the pressure is not going to help. You actually need to do the opposite. So you look at different things. So one of the things, particularly if the baby's on a higher peak than you would normally expect for a little baby. So I myself, in our very prim babies, I rarely use a peak more than 5 or 6. But some people do use high peaks, and in some circumstances, higher peaks are needed. So I'll look at the ventilation and go, that peak's kind of high. Is that the problem? So I'll turn the peak down a little bit at a time. I'll watch what the ventilator does in terms of the ventilation pressures. I'll watch what the oxygenation does, because if the baby's over-distended, the oxygenation may improve. I'll watch what the blood pressure does. If the blood pressure improves, I'm definitely over-distended. If I reduce the peak and the baby doesn't get better, in fact the baby gets worse, then I know I've guessed wrong and I actually need to change the ventilation in another way. But there are ways that you can use all the information on the ventilators and on the monitors to try and decide why this baby is behaving so bad. And then of course the other thing is, the other part of the equation is the circulation. So the circulation, as we talked about before, a very important part of oxygenation is diffusion through the lungs. If your circulation is poor, then your blood diffusion through the lungs is not very good. And the reason why you've got oxygenation problems is not because of the ventilator, it's because of the diffusion. And there are ways that you can sort of look at that. You look at the blood pressure, you look at the capillary return, you look at if you've got blood gas, you look at what the lactate's doing. And certainly one of the things that I've learned with the very small babies is a lot of the art to getting it right is balancing the cardiovascular side with the ventilation. It's a mistake to think that oxygenation is all about ventilation and spend your time just playing with the ventilator. In fact, the ventilator may be doing a perfect job, but because the circulation is not very good, it doesn't matter what you do with the ventilator, nothing's going to change. And a clue to that is you make ventilator changes which should make the baby better, but nothing changes. That's when you go, okay, it's not the ventilator, I need to look for other things, and it's mostly the circulation. So a lot of the problems that I've seen with babies have ultimately died where people say they're unventilatable. In fact, the problem was the circulation was good. And of course, when they were spending 2 or 3 hours changing the ventilation all the time, changing the style of ventilation, high frequency, conventional, nothing changes. The baby was all along trying to tell them it's not about the ventilator, it's about I need better cardiovascular support, and if you fix that, and the clue to that is when the CO2 exchange is relatively easy to do, but the oxygenation is your problem, it's more likely to be cardiovascular than it is ventilation. So usually when you're ventilating a baby and they've got really sick lungs, both the oxygenation and the ventilation are a problem. If it's just about oxygenation and the ventilation is easy, you're probably dealing with pulmonary hypertension or poor circulation, and you need to focus on those things. Any questions?
Yeah. hỏi gì mấy bạn.
Tidal volume is mostly about CO2 exchange. So when we're trying to sort of work out our ideal tidal volumes, the thing we're mostly looking at is the CO2. If the usual sort of, or the difficult situation comes where you know you need perhaps a tidal volume of 5 mils per kilo, but for the ventilator to deliver that 5 mils per kilo, you need very high pressures. And that concerns us because we're worried about what the pressure is doing to the baby's lungs, causing damage, risk of pneumothorax, risk of severe chronic lung disease. So then you think to yourself, well, I have to do something here. So in that situation, one of the things you might ask yourself, particularly if the peak's been set a little bit higher, is do I need to reduce the peak? The other situation where the peak might help is you're on, say, peak of 5, and when you do the X-ray, it shows the lungs to be very small, and there's no history suggestive of oligohydramnios, pulmonary hyperplasia. So the most likely reason why the lungs are very small is you just haven't got enough mean airway pressure to recruit those lungs. And so in that situation, doing a gradual stepwise increase in peak to see if you can improve oxygenation. That's what I would do. So that's where having a chest X-ray can be very helpful. If you've got sort of normal lung volumes on the chest X-ray, you've probably got the right peak, and you have to think of other problems. If you've got low lung volume in what you think should be normal lungs, then it's maybe one of those babies that will respond to increasing the peak. One of the things about high frequency ventilation is you can think in mean airway pressure versus CO2 exchange, and you can change those two variables without affecting each other. So high frequency is a very good ventilation technique for recruiting lungs, and that's where you can use that recruitment maneuver that I explained. High frequency is the ideal way use of recruitment maneuver rather than conventional ventilation. And we can talk about that when we talk about, if you want to talk about high frequency ventilation.
Hương hỏi thở máy, hỏi gì cũng được, chọn có mốt thở cũng được.
Currently return pulmonary hemorrhage. I want degree 7 or 6
or higher. You keep going up until the baby stops trying to die on you. Usually what you see is, so when the baby first has pulmonary hemorrhage, so first of all, we need to remember that pulmonary hemorrhage is not the true hemorrhage. Pulmonary hemorrhage is really hemorrhagic pulmonary edema. So it's lung fluid with red blood cells in it. And it's all about pressure balance. So basically the reason why you have a pulmonary hemorrhage is because the pressures in the pulmonary capillaries are higher than they are in the airways and air sacs. So the fluid just suddenly floods up the airways, obstructs the airways. Now, generally speaking, one of the mistakes people make is they respond to that by suction, trying to suction the blood out. The problem with that is when you put a suction catheter down there and try to clear, you actually even further reduce the pressure in the airways from the suction, and so you actually encourage more fluid to spill in. So generally speaking, unless, I mean, sometimes you get pulmonary hemorrhage that's so severe that it's flooding up the ET tube and into the ventilator circuit, there you probably have to briefly suction to try and clear, but your emergency response is to just increase the mean airway pressure until the fluid starts going back down the endotracheal tube. Then you start to see chest wall movement as you're clearing, pushing the fluid back from the airways and alveoli into the interstitial tissues. So what I'm looking for is I keep increasing the mean airway pressure until the fluid starts disappearing. More importantly, I start to get chest expansion again with the ventilator. Now I've gone to peaks as high as 9 in the acute situation, which kind of sounds scary. What I often do in that scenario is once the baby is reasonably stable and not trying to die, I will then change the baby to high frequency, because high frequency is a better mode of ventilation when you need high mean airway pressures to still be able to achieve good ventilation. And also the advantage of high frequency is it's easier to adjust the mean airway pressure in small steps. But yeah, mostly pulmonary hemorrhage is about mean airway pressure. I've kind of learned that as long as you need to be bold, you need to be prepared to just turn that peep up and not worry about the number. Don't look at the ventilator, look at the baby and just keep turning it up. Once you've recovered the situation, then you can maybe start cautiously bringing it down a little bit. But the trick is very much all about the mean airway pressure. It's interesting, we, in our nurseries, we very rarely have a baby die from pulmonary hemorrhage. And there are a number of reasons for that. The main time we have babies die from pulmonary hemorrhage is when we think we're being really clever and we extubate the baby because we think they're ready to extubate, put them on CPAP, and 2 or 3 hours later they have a massive pulmonary hemorrhage. And because they haven't got an endotracheal tube and they've got all this blood coming up and it's really difficult to ventilate, it's almost impossible to try and stabilise them. If they have a pulmonary hemorrhage on a ventilator with an endotracheal tube in, it's very, very much easier to stabilise them if you respond. The first aid response is mean airway pressure, and then you look at all the other things that might be contributing to it. I've got a presentation on pulmonary hemorrhage. In the newborn period, acute RDS is not coping on CPAP. If you put the CPAP up to 9 or 10, all you really do is you just delay intubating them, and they're often sicker when you go to intubate them. So we, in our small babies under 34 weeks, if we start a baby on CPAP, what we say is, if we can't manage the baby on CPAP of 8 in 30% or less oxygen, then we should give them surfactant and either ventilate them or do it as mist. The second situation of CPAP is a baby who's been on the ventilator and comes off the ventilator, and you put them on CPAP to help them cope with extubation. Now in that, and there's sort of recently been some really good studies on this, but babies on high CPAP, very prim babies who've been ventilated, who were extubated to high CPAP, do better than babies extubated to low CPAP. And I guess for me that's something I've always known. I would typically extubate a very preterm baby to a CPAP of 10, And then what I'll do is I'll watch them over a few hours. If they look fantastic, if they're breathing comfortably, they're not needing a lot of oxygen, I'll start to bring the CPAP down bit by bit, maybe back towards 8. A lot of the time when you try to do that, they start to breathe more worker breathing, and that tells you that they need the higher CPAP. There was recently a study done where they compared high CPAP to, I think it was CPAPs of 7, and they found that the babies on CPAPs of, I think it was up to 10, were much more successful with extubation than babies on CPAP of 7. Because the problem when you start with a CPAP of 7, if it's not enough pressure, they start to de-recruit, they start to lose lung volume. And as you've seen from those curves, once you lose lung volume, it's much harder to expand the lung than it is to keep the lung expanded. So if you use a lower CPAP pressure and the baby starts to lose volume, it's very difficult to rescue them from that by putting the CPAP up. So I prefer to start high, knowing that the baby will be at least well recruited as they go on to CPAP. And then if it looks like they're doing really well and don't need that pressure bringing it down, the main problem with the higher CPAP pressures is they get big belly. And so that's why if you can bring the CPAP pressures down once they're stable, it's possibly helpful. But if you start low because you're worried about CPAP belly, you're much more likely to end up putting that baby back on the ventilator. And extubation failure is a big setback. If you extubate a very small baby and they fail, it often takes you many days to get back to where you were before that. They often have many hours of high oxygen and much higher ventilation requirements. So trying to avoid extubation failure is really important.